Today we are going to talk about composites, the adhesion mechanism of the composite, how does the composite makes bond with the tooth, what is composite actually, and what are the light curing requisites of the composite and things like these. The learning objectives of this lecture would be what is the configuration factor, C factor, what are the differences of adhesion to enamel and adhesion to dentine, what are the different types of composites we are going to use, such as microhybrids, hybrids, nano composites, and traditional composites. In dentistry, adhesion of the resin based material to tooth structure is caused by four mechanisms, as you can see on the slide. First is the mechanical adhesion. The resin penetrates into the tooth structure, which is defined by etching prior to the application of the bonding material. Then it is the adsorption of the bonding material onto the tooth surface. Another mechanism is by diffusion, and the last one is a combination of all of these, such as in the case of glass ionomer cements and nano layering of universal bonding agents. So it is a combination of mechanical, adsorption, and diffusion. So we are going to talk about enamel bonding. As you can see, in enamel bonding, we are just etching the enamels and using 37% phosphoric acid. It is going to etch the enamel surface, reveal the rods and interrods, and a combination of all these mechanisms. And this will then we will apply the bonding agent. The bond will penetrate these rods and interrods and create a hybrid layer. The hybrid layer will be composed of both the enamel and the bonding agent, and to this hybrid layer, the composite, any composite we are using, the light cure or the dual cure one in this case, will bond to this bonding agent. Now coming forward to the dentine, so if the cavity or the tooth preparation we are using dentine bonding agent, there are many challenges in bonding the composite to dentine. First of all, as you can see, dentine has a lot of inorganic substrate. The collagen, it has dentinal tubules which are filled with dentinal fluid. It has certain millimeters of mercury pressure, and it is it is hydrophilic. So the hydrophobic composite and its bonding agent and anything else is not going to work really well with it. It is not as highly mineralized, then it has configuration stresses, it has shrinkage stresses. These are all going to happen. So we are going to look at the next slide. Low mineral content, such as high amount of collagens, different type of collagens. All the dentinal tubules of dentine have dentinal fluid in it, which is non hydrophobic. It is hydrophilic material, and these dentinal tubules increase in number towards the pulp and increase in diameter as well. So as we are going deeper, the dentine is getting more and more hydrophilic. The bonding agent is going to be very difficult and very hard for it to penetrate unless it has hydrophilic monomers, as you can see on the slide. What is configuration factor? Configuration factor is number of bonded surfaces as compared to the unbonded surfaces. In the case of class 1, that is the occlusal preparation, in which we put bonding agent, or the composite increment. The composite increment will bond to all the surfaces such as the floor, pulpal floor, mesial wall, distal wall, buccal wall, and lingual wall. So it has 5 surfaces against one surface, that is the occlusal surface of the increment of the composite, which is unbonded. So it will exert a pull on the bonding agent from all surfaces. This surface, buccal surface, lingual surface, and the pulp floor, they will all pull the composite towards each other. So only the occlusal surface, the upper surface of the filling, is bonded. So this is very high configuration factor. I can explain to you with the diagram. As you can see, we have a class 4 restoration on the left and class 1 restoration on the right. In the class 4 restoration, only one surface is bonded, that is the incisal edge of the preparation, not of the actual tooth. And three surfaces such as buccal surface, palatal surface in this case, and a mesial surface, these are unbonded surfaces. So the stresses on the hybrid layer of the bonding agent and dentine are very low. The bonding agent is just being pulled by one surface, that's it. In the case of the diagram on the left, I have told you earlier, mesial surface is also pulling at it, the bonding agent composite. At the bonding composite, the mesial surface is also pulling at it. On the distal surface is also getting pulled. On the pulpal floor, it is also getting pulled when the composite is polymerizing and getting shrinkage. So only the occlusal surface is left. So the configuration factor is very high and challenges to the bond are increased. What is the reason of shrinkage? Composite is polymerizing. You can see in this diagram, as a composite is polymerizing, many large chains of acrylics or all the resin composites are acrylics are getting joined together and the spaces are getting eliminated. So the composite which was like this, so it joined and the space in the middle is reduced. So it will cause shrinking. Previously, in older editions of Art and Science, Study and Art and Science of Dentistry, operative dentistry, it was up to 6%. Now it has been reduced to only 2 to 2.4%. Further editions of the silo range are reduced it further. Now, how are we going to minimize configuration stress shrinkages? First of all, you can use a thick layer of primer. Use a primer that has a low content of filler in it, not much lower as a traditional bonding agent. It has some filler in it, so it can act as a cushion for the stresses. Or use a flowable composite as a liner under your restoration, so it can act as a shock absorber. Or if you cannot use the flowable composite or you do not have that bonding agent with the filler, resin modified glass iono cements are very common, so you can use them. It is called bonded based restoration technique. Or use the soft start polymerization of the light cure composites. That will be reducing the configuration stresses on the composite. The most common one we all tell to our students and colleagues that do not fill the composite into the prepared restoration all at once, so the stresses of the C factor, configuration factor will be higher. Use incremental placement. That is the most common way to reduce configuration stresses. Now we're coming on to the next slide. I am giving concept of the smear layer. What is a smear layer? Smear layer is formed when we are doing the tooth preparation. It is the shavings of dentine, enamel, and they are partially occluding the dentinal tubules and enamel interrot. It is loosely placed in the dentinal tubules, so it can affect the penetration of our vigorously applied bonded agent into the dentine. And if we incorporate this smear layer into our composites, the bonding strength are less than 20 megapascals. Now we are going to have a review and control the polymerization shrinkage. It is same as the polymerization, or it is same as the configuration stresses, the C factor stresses reduction. You are going to use light for recommended amount of time. If the composite requires 500 millijoules, you cannot use a big light to cure the composite like this much size and you can say I will do it in 1 second. This will not be okay. So you have to use according to manufacturer instructions. If manufacturer says you are going to light cure it for 40 seconds, you have to light cure it for 40 seconds at the appropriate required wavelength. Another strategy is same as C factor. You are going to cause incremental placement of composites. Reduce the distance between the increment or between the composite and the light source, so the penetration of light is deeper, and use other layering techniques as you can use. Now we are going to look at our current bonding systems. There are first three generations which can be of historical importance to you. Now we are going from fifth generation or fourth forward. As you can see in the fourth generation, they still were not accepting the procedure of etching enamel or dentine using phosphoric acid or anything like that, so the bondage strength were low. In the fifth generation, there were two types of bonding agents, etch and rinse, etch and dry. Etch and rinse first had three steps: etchant, then primer separately in a bottle, then a bonding agent. Then they simplified it. Etchant remained separate, primer and bonding agent in etch and rinse was combined, so it became two step. The self etch has gone much further. First there were two steps, then the etchant, primer and bonding in one bottle. Then they tried to further simplify it by using it one step: etchant, primer, bonding, everything went into one bottle. Then they went a bit further and used the universal adhesive, which has 10 MDP, methyl acryloxyl diphosphate or something like that, if I'm pronouncing it right. The universal adhesive can be used for bonding composites, for bonding resin restorations, for bonding ceramics, glass matrix ceramics, or bonding indirect restorations or fixed crowns or anything like that, or bonding the root canal, bonding and etching of the root canal posts and resin or fiber posts and many things like that. So in the next diagram I am going to show what happened. First diagram, in the part A we are saying there was a smear layer present. We tried to bond it, but smear layer did not let us penetrate the dentinal tubules or enamel rods. Penetration was less, so the bond strengths were less. In B, we are showing you that smear layer and phosphoric acid etching caused the destruction of the smear layer. The smear layer was removed, so micro retention or resin tag formation from the bonding agent happened. In the C, we are going to show you that if we are preparing enamel by etchant, which is not along the enamel rods, rather parallel to the enamel rods, it will not cause any bonding because micro tags will not be formed and they will not be deep enough for appropriate bond strength to develop. Next diagram slide is just for reference purposes. In the fourth generation, there were three steps in etch and rinse. Then they developed it further to make it two steps, so simplified the application of etch and rinse. Then they said, no, we are going to use etch and dry. We do not have to rinse it. Etch and dry first were two steps. Then the etch and dry became one step when they used hydrophilic acidic monomers. The etchant, the bonding agent, and everything went into one bottle. So there were two generation of self etch and two generation of etch and dry. These systems, the etch and rinse system, were excellent as they had more bond strength. They had removed the smear layer entirely. They were also known as total etch adhesives. They were composed of etching agent, most commonly 30-37% phosphoric acid, hydrophilic monomer primers such as HEMA, or hydrophobic bonding agent which was bisphenol GMA. Then they combined the component 2 and 3 into primer plus bonding agent, and etchant was remaining separate in these adhesives. After etching, you have to wash the enamel and dentine to remove the phosphoric acid and then bond composite to it. You can see on the next slide. In this slide, you can see etch and rinse happening. There were smear layer on the prepared dentine. You etched it, you exposed the collagen and dentinal tubules. Then you prepared it with the two-step bonding agent, which infiltrated the collagen and wetted the collagen, as well as penetrating as a resin tag into the dentinal tubules. This also caused problems of the etch and rinse. When the prolonged drying caused this collagen, which is exposed, to collapse, resulting in less depth of penetration of the bonding agent into the collagen. So the bonding is compromised. So they tried to use another method called moist bonding technique. This moist bonding technique basically means when you dry it for a prolonged periods of time, you have to re-wet the dentine with the non-water type of liquids such as isopropyl alcohol, acetone, or your bonding agent. You have to rub it vigorously to make the collagen, which was collapsed, refill or re-wet and expand on its own by hygroscopic expansion. And the depth of penetration of bonding agent is increased. Bonding strength is improved, so you do not have the problems of prolonged drying. Now coming forward to the self-etch adhesive. The bonding agent is combined with the phosphoric acid. The bonding agent itself will etch the dentine, so it will not remove any smear layer from the prepared dentine, and it will include the smear layer, rather incorporate the smear layer into the dentinal tags. First their etchant and primer, then a bonding agent. It was 2-bottle system. Then it became etchant, primer, bonding agent in one bottle systems. Further developed were universal adhesives, we included with 10 MDP, to be used in multitude of things other than bonding composites with them, such as fiber post bonding or bonding of ceramic crowns and zirconia crowns and many things like these. The universal adhesives were used for that. The self-etch adhesives came with the 3 type of strength of acids: mild self-etch, moderate self-etch, and high stretch. The high strength self-etch caused appropriate etching of dentine, but were not okay with the etching of enamel. So you have to do selective etching of the enamel to achieve ideal bonding strength with these bonding agents. The universal adhesive, as you can see, has additional factor of nanolayering. The nanolayering means it can cause a chemical bond due to its incorporation of 10 MDP along the resin tags. It can make a chemical bond, which is referred to as nanolayering in dentistry. It has multiple uses. Universal means it can be used in etch and rinse way or etch and dry way or any way of the composite bonding. Now we are coming forward to leakage and micro leakage. In the etch and rinse adhesives, we are going to remove all the smear layer. Then the resin tags were formed. The resin tags were formed inside the dentine when they were cured. The etching exposed matrix metalloproteinase enzymes in the dentinal tubules, which were activated by the phosphoric acid, which was removed from the cavity earlier, but was not removed in its entirety from the dentinal tubules. The matrix metalloproteinases cause the degradation of the resin tags and cause leakage along the resin tags, known as micro leakage, which was the leakage of oral fluids, bacteria, and anything along the tooth end resin restoration or composite restoration interface. Basically, this is a leakage of oral saliva, bacteria, and everything along the tooth surface and composite interface. So it is called micro leakage. Nano leakage was happening further down into the resin tags. As I was telling you before, the micro leakage was happening around the cavity. The nano leakage was happening further down in the resin tags and was caused by hydrolytic degradation of the resin tags. You can see in this diagram what do I mean. The dotted yellow line is showing you this is the composite interface with the resin. This is the micro leakage, and in the resin tags, along the resin tags, what is happening is the nano leakage. Now onto the we have done the etching. Now we have placed the bonding agent, either it is etch and dry or it is self etch bonding agent. What we are going to do is we are going to use a light source. That light source is going to start the polymerization reaction of the light cure composites. As you can see from this image, the benzoyl oxide used in cold cure composites or such as self cure composites, the composites which cure on themselves, we do not need any light source or heat source, is benzoyl peroxide. Then they started using camphoraquinone, which caused the yellowing after some time of the composites. Camphoraquinone was activated in the visible light spectrum such as the blue light and peaked at 480 nanometers. Then they started using other tertiary amines, such tertiary amines for tertiary and quaternary amines for to be used as co-activators in conjunction with camphoraquinone, so that the multiple light sources can be used. Here you can see there is an activation reaction. First you are going to generate a free radical by any means such as heat, light or anything. That radical will start joining other free ends of the multiple monomers or polymers in the resin matrix. Then this resin matrix is going to polymerize and all the long chains are joined, and finally a free end will join at another free end, like it will come a full circle and the polymerization will be complete. So there are different things which will affect how well your composite is cured and how well it's going to function in the oral cavity full of saliva and occlusal forces. First is the depth of cure. Depth of cure means how deep is the interface between the incompletely cured composite and the cured composite. If your light is far away from the filling, then the depth of cure will be just first initial 1/3. If your light is really near, then the full of the composite increment will be cured. If your increment is not 2 mm or less than 2 mm thick, it is more thicker or 3 mm, so it is not going to be fully cured. If you are not using the curing light completely, it is not fully charged and it just turns off before the 30 seconds time roughly, so it is also not going to cause full curing or depth of cure. It will leave small chains of the polymerization. If you are not using the appropriate wavelength, it will also not penetrate the increment of composite fully, so the cure will also be compromised. As see in this image, this image is showing if you are putting the curing light on the left, 65 of the composite near the surface is cured and 15%, 35% monomer is left, while at the deepest portion 15% of composite is cured and the rest is remained uncured. On the right it is going to show you that if you keep your light away from the composite fully, then the degree of conversion is compromised. Now we always talk about soft start, pulse delay technique and other techniques. Soft start happens in two ways. First, you start curing with low radiance, low power of the light that is delivered to the composite. Then you progressively increase it until the curing time is reached. So it is ramping up of the power. First it is 2 millijoules, then 3 millijoules, 4 millijoules, up to the maximum amount that is required. Another is pulse delay. You are keeping it at lower level, 2 millijoule, 2 millijoule, 2 millijoule along the time. Then you go increase and give a final pulse of full intensity of the energy you are going to provide to the composite. But this is debated. This type of pulse delay technique is debated as it causes shorter wavelengths of the composite in the increment, shorter lengths of the polymer chains in the composite increment. Coming forward, now we have light cured the bonding agent. Now we are going to do the tooth preparation or composite restorations. We are traditionally using it for class 1, class 2, class 3 and class 3, class 4 and 5. So we are going to discuss only some parts as this is more clearly elaborated in our clinical rotations. We have studied what are composites. Composites are materials composed of two type of things such as a matrix. Matrix is made of hydroxyethyl methacrylate, UGMA, TEGDMA, many kinds of acrylics such as it will make the matrix around the filler particles. Filler particles are most commonly quartz silica, and some have recently introduced zirconian side called it zirconomers. Some have started to introduce cured glass ionomers as guyomers in the composites. Some have tried to incorporate another type of polyacid modified composites. The meaning of the thing to say is that the matrix is composed of different type of acrylics. Then we are going to use activators which are going to start the polymerization reaction of this matrix, and the main strength of the composite is given by the filler particles. The filler particles are, as I told you, quartz silica, glass ionomers, cements in case of guyomers, and many other things in that. Sometimes we have recently introduced siloane. We do not have introduced, rather they are introduced siloanes to counter the polymerization shrinkage that happens in the matrix. Now previously they were self-cure, still used as self-cure or cold cure, which has activator in one of the tubes. You mix two tubes of the activator and the other base tube, then it will start curing reaction and it will polymerize and set. Then there was dual cure, which was cured by either the light or the self activation. Then they started to use light cure, which is the most widespread these days. First it was being cured by ultraviolet light, then we came up to campheroquinone. We are using tertiamines with it. Now we came into the visible spectrum of blue light. The blue light penetrates deeper into the composite increment, so it is the most widely used. With the advent of LED technologies and argon laser, we are using LED technologies most widely across the world. Then the quartz halogen lamps, quartz tungsten halogen lamps and other plasma arc lights are not used because of their various problems of overheating and short life of the bulb, such as things like these. Then composites were classified on the basis of their filler particle size. The filler particle in traditional composite were up to 40 micrometers. Then they reduced and introduced it into the traditional composite. Traditional composite had two types, such as traditional filler particles and particles up to 4 micrometers. So it was called hybrid. This caused increased polishability of composite and less of the bulk fracture when composite was polished. Then came the nanotechnology, the atomization of filler particles. Now we have composites which have a particle size of less than 1 micrometer. So this caused increased filler content up to 75% or so of the composite. So improved strength, improved polishability, and use in posterior surfaces. And on the basis of light curing, I have already told you that there are light cured composites, dual cured composites, and cold cure or self cure composites. And we have just reviewed the adhesion of the composites to the tooth substrate or root canal dentine or anything like that. There are two types of the bonding agents, such as etch and rinse bonding agent and self etch bonding agents. Now we are going to talk about the preparation of the tooth, where and how you will place these composites and their bonding agents. Where will you put the composites? Where will you use the composites? Composites will be used in class 1, 2, 3, 4, and 5 and 6 and all kinds of restoration. It will be used as it is tooth color restoration. It is very high in demand. Then on grossly broken down teeth with loss of tooth structure, gross loss of tooth structure, you are going to use it for core build-ups and foundation restorations before putting on a fixed restoration such as a fixed partial bridge or something like that. It can be used as resin based sealant. It can be used in preventive resin restorations, in aesthetic enhancing procedures such as gap reduction between anterior teeth, and no prep veneers, partial veneers, full veneers, or treatment of localized enamel hypoplasias. It is used too much of the dental terminology. Some tooths, such as lateral incisors of upper arch, are reduced in size congenitally, so they can also be modified using these composites. In providing temporary crowns to a person who is going to receive permanent crowns after some times, in case of implant retained restorations or in case of long arch restorations, where the patient does not have time to wait for the permanent restoration to come, so temporary bridges and crowns are made with these and inserted into the patient's mouth. We cannot use composites. The way we cannot use composites, as you have studied earlier, nano leakage, micro leakage, many things like this. The composites cannot be used where you cannot use rubber dam. The composites cannot be used where there is high occlusal pressure, the patient is into the physical sports, high contact sports, or the biting forces of the patient is very high. The restoration is extending on the root surface. Why there is a problem? There is a problem of root surface having only dentine. There is no enamel, as you know. And it is very near to the gingival margin. Very near to the gingival margin cause isolation problems. There is gingival clavicular fluid, there is gingival bleeding, something like these, and very hard to place adequate rubber dam isolation. And also depends on the operator experience. The newer the operator, the harder it is to place the composite, and greater the chance for the composite to fail if you are not very confident with placing composites and you only use other type of restorations. Moving on, as I the caries or caries prone fissure, caries fissures will be opened, they will be etched, bonded, and other susceptible fissures will also be etched and bonded and sealed with composite. The guideline for preparation is only that you are going to only use only the caries tooth structure. You are not going to do extension for prevention in this type of materials. And there is no requirement of occlusal convergence, as it is going to be micromechanically retained into the tooth, not chemically retained. Micromechanically retained, cannot chemically retained into the tooth structure. In case of large, moderate to large, class 1 cavities, tooth preparation, we are going to first make an outline form with the elongated pear-shaped burr, as you can see on the image. Then you are going to use any kind of liner, base, or something like that if it is needed. If you are near the pulp and remaining dentine thickness is less, you are going to use RMGIC or MTA or chemically modified calcium hydroxide paste such as dical or theracal, their own trademarks. I do not know these products or do not claim any trademark for them. This is their trademark. So first you will use liners to place in the cavity to seed the dentinal tubules. Then you are going to use composites to restore these kind of restorations. As you can see in these steps, in the A we have made a cavity, then we are using a liner in part B on the deepest part of the pulpal floor in the maxillary tooth. Then the pulpal floor is made horizontal. We are trying to make one cusp in the part D. Then we are going to make another cusp in part E, F successively. Then we have taken occlusal high spots and we have polished that restoration. Coming on to the class 2 preparation, as you can see the proximal surface of the teeth of the posterior teeth. On the anterior teeth it is called class 3. Do not confuse them. Here I am really surprised that the South Asian edition of Study Event Art and Science of Dentistry says that we can leave the tooth joining the adjacent tooth when we are preparing for class 2 proximal box. Another type of diagram here shows if the marginal ridge of the tooth, distal mesial marginal ridge of the tooth is intact and is not carious, and caries you found is near the cement-enamel junction or on the root, you are going to use the slot preparation. You are going to, as if it is the tooth, you are going to, how can I explain that? You are going to access the carious linear from the buccal side or the lingual side. Make just a slot, use retentive grooves on the incisal part and the gingival floor part, and proceed with the same procedure such as etching, bonding and restoration. Now I am going to show you how to make tight contacts. This is a instrument used by Resin Dental, the contact former, and also a O-ring used by Triodent. Again, these are their trademarks. I do not claim as my own. This is their trademarks. While you have placed composite into the proximal box of this molar, you are going to hold the matrix band, in this case the sectional matrix band, away from the tooth by putting this instrument and pulling it like this towards the adjacent tooth. So when the composite is curing, the matrix band does not come and fall down on the tooth. As you can see in this diagram, these have separate attachments for mesial and distal. Now here we come in large class 2 tooth preparations. There are steps of cusp capping. There is a thin cusp. You are going to put depth cuts with the side of the tapered Fisher bar or any other 169L or some bar like that. Then join these depth cuts to smooth them out, and you have a reduced cusp. This cusp will be covered by composites to prevent its fracture. Coming on to the class 3. Class 3 is in the most area of anterior teeth, interproximal area of anterior teeth. Very good approach would be to try to access this caries lesion from the lingual surface. The buccal surface is visible in maxillary anterior teeth, so you are not going to access it from buccal surface unless you do not have any other option. Access it with the buccal surface. Remove the caries by moving the burr along the convexity of the tooth. Do not go straight in. Respect the contours of the teeth, such as admesially or distally tooth is round and convex. So your burr should not go like this. Your burr should go around the contour, maintaining the depth of just inside the dentinal enamel junction, like 0.2 mm deeper into the dentinal junction. It will already give you the depth of 1.5 to 1.6 mm. If needed, it is a large class 3 tooth preparation. You can use incisal pit and gingival groove in this type of preparation. The preparation will be flat on the gingival side, and on the occlusal part or incisal part it is going to taper along the tooth surfaces, buccal and lingual palatal tooth surfaces, and it will be a triangle. How are we going to restore this? You can see we are going to restore this by first the cavity, putting on the rubber dam, then doing the etching of either etch and dry or etch and rinse bonding agent. Then we are going to place a matrix band wedge, as you can see, contour the matrix band. Now you can see matrix band is placed with the wedge. Then here we are going to put bonding agent. When filling instrument is filling material is placed, the matrix band we contoured is folded back onto the tooth surface, making sure that it is not over contoured or under contoured. Then placing the light cure. Coming on to the class 4 composites. Class 4 is the extension of class 3. First class 3 was between the two teeth. Class 4 means the corner of the tooth has also broken down. As you can see in this diagram, there are various types of class 4. In the part D, you can see that it is triangular shape, and you can place a retentive groove using a small number 1/4 round burr. The image below is showing the patient's teeth of a child who has erupting maxillary incisor. Thank you to the patient for giving us the opportunity rather to have this photograph. Now we can see here the steps of the restoration. The patient is showing you that right upper central incisor has broken its incisal corner. The 169 number L burr is used in step C for placing a large 45-degree bevel, 2 to 3 millimeter in size, on the mesial surface of that tooth. Then it is being etched. After being etched, it is going to be, in the next image you can see the bevel is placed more detailedly, and a gingival groove is placed to retain this restoration, and tooth is pre-wedged to tooth from the adjacent tooth so that the contours of the teeth can be maintained. If it is not separated, the matrix band will collapse. One tooth will be this size, other tooth will be this size. So you have to put the wedge inside so that we have this much surface, and composite can restore the proper contours. That is what operative dentistry is all about. After that, we are going to use etching, bonding, and composite placement. Pull the matrix band over it and cure it. In the class 5s, you can know that there are big class 5 restoration and small class 5 restorations, as in this diagram. We are going to use number 212 clamp, the favorite clamp for class 5. We are going to isolate, repair it. If needed, we are going to place occlusal and gingival grooves. Then we are going to do etching. If needed, we are going to do indirect pulp cap or direct pulp cap. After etching, we are going to place composite, light cure it, as you can see, then it will be polished. Polishing, we can use different things such as the 12 fluted or 40 fluted tungsten carbide burrs on the left, or polishing kit on the right. General rule for the polishing kit is that you go from the darker color to the light color. Darker color is the blue, then we are going to come to the gray, and then we are going to come to the white. The cone shaped things are used for the occlusal surfaces or in between the incisors or the palatal surface of incisors, or the polishing the cusps. According to your situation, you can use them. On marginal ridges and inclines, we are going to use the nib shaped, the flat ended conical things. That would be all our tooth preparations for class 1, 2, 3, 4, and 5. The remaining topic of that composite is the color selection, how we are going to do color selection. As you can see the light falling on my face, the color selection triangle means that it should be as natural to the natural light as possible. It should have a color of 55,000 to 65,000 candelas, right? The second thing would be my eye should have normal vision. I should not be color blind. Third thing is the tooth. The tooth you are going to do the shade selection for. It should be viewed perpendicular from 1 feet distance apart. You are not going to look at my tooth from here. You are not going to look at my tooth from this side. You are not going to look at my teeth from when I am lying down. You are looking at it perpendicularly. This is the tooth surface. You are going to look at perpendicularly at 1 foot distance or 30 centimeter distance. Then you should have a reference how to record this shade of the tooth. There are 3 types of reference guides, such as ceramic based, plastic resin based, or customized. Customized means take a block of the filling material from your available composite kits, you place on a stub or something like ice cream stick or like that tongue depressor or something like that. You use it your composite to place on it. All different shades of your composite kit are placed, so you have your own customized shade guide. Then they try to use the conventional shade guides by Vitas and Fabric. This is the conventional shade guide. This is called conventional shade guide A1, A2, A3, B1, B2, B3 going towards D. Then they said no, this shade guide is not okay. Now we are going to make another shade guide. It is called Vita 3D Master, in which teeth are grouped into 4 major shades A, B, C, and D. Then there is increasing and decreasing chroma, then increasing and decreasing hue. You can refer to their user manuals or the textbooks such as Stud Events, Art and Science of Operative Dentistry for this shade guide. How it can be used for bleaching the teeth, another shade guide is used, that Vita Bleached Guide. For more detail, refer to the text. As you can see, this is the shade guide, the classical Vita classical shade guide. It has 4 hue groups: 1 group, 2nd group, 3rd group, 4th group. Reddish gray this end, reddish brown, reddish yellow, and gray. I never understood it properly. Within each group you are going across as chroma is increased. This is the darkest of this group, this is the lightest of this group. More color is inside, less color is inside. Another shade guide is Vita linear shade guide, which is based on the value. The lighter, the whiter of the color is the darker of the color. There are 5 different grades of that Vita linear shade guide. In these 5 there are vertical arrangements of teeth. For example, if this is the first group of the A of the shade guide, it is called L, then M, then R, In that, if it is lighter it is placed here, if it is darker it is placed here, something like more chromatic, rather less chromatic, more chromatic. This is where we are going through the value of that. So it has 15 different groups, and there is also a bleached guide or tooth guide or anything like this. Then comes the spectrophotometers or the cameras of your DSLR cameras, which have polar filters, which can better be used to record the tooth shade to make ideally the tooth color distortions to which are placed on single anterior teeth.